Okay, hello everyone and welcome to this AIOS module on OCT in glaucoma. At the outset, I would like to congratulate Dr. Tanuj Dada, Professor Tanuj Dada and team on this wonderful initiative. And I am sure at the end of it, we'll be left a lot enriched on this topic or difficult topic of OCT in glaucoma. My topic for this event is basically OCT in glaucoma, basics, machine types, and scan protocols. Now, this is the where it all starts. After this, all the subsequent things fall into place, and then at the end of it, you get a nice summary on which you make a clinical decision how to treat the patient on basis of imaging and what place it has in your armamentarium. I have no financial interest in this presentation. The devices mentioned are purely the devices that have been used in my entire career, and accordingly, whatever examples were found appropriate have been added in this particular presentation. So when we talk about OCT in glaucoma, we usually see such kind of presentations that are given to us for interpretation. Now, there is a vast difference between these two images, and we leave it at that at the beginning. At the end of all the entire education module, you will be in a much better position to differentiate yourself and comment on how these images actually differ. So understanding the difference in such kind of printouts is paramount and is very, very important for successful inclusion in your practice. So the aims of this talk basically are understanding the unique nature and demands in glaucoma imaging, overview of available technology and its nuances, application of the above knowledge to make instrument-related decisions in terms of purchase and use, and harness the complete potential of this technology in patient management and decision-making. So what is the unique role of glaucoma imaging in the management of glaucoma patients? See, as we all know, glaucoma is a chronic progressive optic neuropathy, and it leads to irreversible visual disability or visual impairment, in worst case, blindness. The monetary and psychological consequences and the tangible effects on the quality of life are massive, to say the least, and hence a very, very rigorous kind of approach is required for management of glaucoma patients. So as far as the aims of glaucoma diagnosis are concerned, it's important for us to identify disease, and not only that, the more important thing is to identify progression. As we know, it is a progressive optic neuropathy. Data required for such kind of progression identification has to be reliable, reproducible, and of the highest quality. The stakes for precision in this are very, very high. If you see these two particular research works by Leung and Huang, it's very, very obvious to us that structural progression takes place much before functional progression takes place. And we have a good maybe around 2 years of temporal gap between a structural and functional progression, as the literature by Huang suggests. At the same time, if you see the chart on the right, here we definitely know that the gap between the 95th and the 5th percentile of nerve fiber layer thickness is barely around 50 microns. Now, if you want to identify progression, or if you want to say that the difference between the 95th and 5th percentile is 50 microns, you have to imagine the precision by which you have to measure each 5 micron step in the decay of the nerve fiber layer in progression assessment in glaucoma. So it's very, very important for us to understand that precision is the key, and that has to be the most important ingredient of your examination. Another important aspect of glaucoma imaging is that always we have two main pillars to our diagnosis. One is structural and another is functional. But the biggest bugbear, if you see as seen in this particular film, is that when you go to functional progression, the test-retest variability is the biggest drawback, if not the least, in terms of sequential visual field testing. So if you have a very good progression assessment on imaging, which again is not an easy task, which we'll see soon, is definitely going to help us in decision making in those large subset of patients who have a high test-retest variability in visual field examination, and obviously also in the progression in the green and in pre-perimetric disease. So there are various platforms that are commercially available. Now, the more the merrier is okay, but here the problem is which one do you exactly choose and what are the parameters based on which you make this decision. That is very, very important, and we shall see this in very short. So we have this time domain, the spectral domain, and the swept source OCTs, which are there with us. The time domain is now fallen out of favor for the various drawbacks that we'll be covering in the subsequent slides. But the other two are very much available, and then we have to make a decision based on what we know about the hardware and also the clinical experience and the published literature. So going back to the very basics in very short, because a few things are needed to be known before we embark on the journey of understanding the high-end physics behind the machines. Optical coherence tomography in ophthalmology came into existence after the work by Huang and Fujimoto. The nomenclature was also given by them in 1991. It's a non-invasive low coherence interferometry, which is basically using a light of a constant phase difference used for imaging tissues, in which the output is like tissue sections. That's why it is called as a tomogram. So using low coherence interferometry to obtain tissue sections is what optical coherence tomography means. The frequency of the reflected light from the tissue depends on the tissue characteristics, and that gives the image its actual character. So as you see, the incident wavelength on the left side and the differing wavelengths reflected from different tissues depending upon the consistency of tissue, and that will result in a image that has various gradations of reflectance, and that will give you the tissue consistency of the tissue texture. Now, it is analogous to ultrasound in the way that it reflects the echoes, and then we use the interference pattern of these echoes. Why interference? Because if you just want to measure the light speed delay, it is beyond our capacity because the light travels very fast. So what we do is we use interference with a reference arm and a sample arm. And the interference pattern thus generated is used for actual construction of the image. So what you have to, a couple of things of physics, if you really need to understand, is that the shorter the coherence length or the pulse length, higher is the eggshell resolution. This is the clinical or the applied part of the physics that you need to understand. Eggshell resolution is a function of depth. Lateral resolution is a sideways resolution or in lateral direction, and it's dependent on the lens or focus. So important aspect is the eggshell resolution, because if you will see that lateral resolution of most of the machines are nearly similar, it's eggshell resolution which makes the difference. Depending upon how the peaks and the troughs of the reflected waves combine, the wave amplifies or cancels, that we all know. And this principle basically is used you're using the sample and reference arm in the interferometer to generate images in the OCT. The method of light source and the receiver technology differentiates the current methods of OCT that are available. And by tweaking the above two parameters, we can take advantage of the strong points and at the same time suffer the respective disadvantages. So we'll see what are the clinical aspects of this particular nugget of physics as we go ahead. So the application of this technology is the biggest application of OCT in medical science, and that is in ophthalmic imaging. It is a quantitative objective structural test that has stood the test of time, where HRT and GDX have fizzled away with efflux of time. OCT has just stayed, become stronger, and evolved into a very, very structured branch. Almost 30 years of ophthalmic application and refinement have gone behind the current OCT technology today. And the usage of anterior as well as posterior segment machines, separate as well as standalone, as well as with adapters, to give you both the views of the anterior and posterior segment, though the dedicated machines do offer much more advantages over the combined machines. And the rapid evolution in the image quality and scan hardware and software in the last decade have somehow almost respected or been the perfect example of Moore's law in technology, where the speed of technology or the change of technology is almost double every 2.4 years. Now, applying this Moore's law to this on this particular slide, which was the Topcon commercial release in the American Academy in 2018, it shows us that the speed of OCT imaging may vary double every 2.4 years, but actually, if you see, it has risen exponentially from a meager 400 to 1.25 lakh scans per second in almost 20 years. So this is one of the finest examples of how physics evolves very fast, and we have to exploit this in our clinical assessment and in our in the way we practice to help patients in a better way. But always remember that essentially only speed alone may not translate into imaging excellence, though it is an important role in limiting the most painful motion artifacts, which are the limiting point of OCT technology. So again, coming to the physics and tech rolled in together, technologies are divided again. We'll remember into time domain, spectral domain, or Fourier domain. That's a synonym, and a swept source. Stratus, as we all know from Zeiss, was the most studied time domain OCT. It is not used sparingly now, and superseded by obviously by the spectral domain and swept source. We'll just see why. And these machines are sold now by various manufacturers and with varying specifications. The understanding of differences aid in selection of the correct device for the appropriate application in ophthalmology and especially in glaucoma. So if we see the basic difference in structure between the time domain and the spectral domain OCT, the differences are very few. But the basic core of any OCT machine is the interferometer setup that is seen in the center, where you have a light source, a beam splitter, a reference arm, a sample arm, and then the detector. So this is common to all the OCTs. Now, depending upon how the light source, how the detection arm is handled, these devices usually give you the difference in their performance and their output. As far as the historical time domain technology is concerned, I call it historical because it's sparingly used. You don't see a time domain machine nowadays. It consisted basically of a moving mirror, which was the reference arm, and by moving the mirror, you used to scan the different depths of the sample arm. Now, the limiting factor here was the speed of movement of the mirror was always a limitation, and that's why the speed of the scan or scanning speed of the machine was usually less. Now, come spectral domain or Fourier domain OCT by 2006, this photo detector here was replaced by the spectrometer. And the moment that happened, the scanning speeds actually increased exponentially, because the way the spectrometer handles data is completely different from how the time domain setup used to handle the data. So what it does is basically the multiple waveforms that are emitted from the tissue are decomposed by a Fourier transform, what we call the Fourier transform. You just have to remember the terminology, into individual components. So it decomposes complex signals into simple constituents at extremely high speeds. Now, speed is of essence in imaging because you have to overcome the microsaccades of the eye during the acquisition. And here, because the time domain had a moving mirror which had a limitation to its speed, that was a limitation of the time domain OCT scan rate. And also, it led to painful motion artifacts, which were a basic bugbear in utilizing the technology for more extensive use. So now if we compare side by side time domain to spectral domain or Fourier domain OCT, you have, these are the cardinal differences that as we just saw, the time domain uses a moving reference mirror and SLD light source, whereas the spectral domain uses a broadband light source and a spectrometer as a recipient, and there is no moving reference mirror, so it doesn't limit its speed. The scans around time domain were 400 per second, whereas the spectral or Fourier domain is 27,000 to 1,25,000 scans per second, which is a huge quantum leap in terms of imaging speeds. The resolution of the time domain was around 10 microns in actual resolution, whereas in the spectral domain, it is reduced to 3.9 to 5 microns, which is very, very important, as we saw that we are talking about detecting around 50 micron loss from 95th to the 5th percentile. The slow speeds resulted definitely in more artifacts in the time domain OCT, and these spectral domain are much faster than the saccades, and you have a fewer motion related artifacts. So these are the basic, most important clinical aspects of the differences in time and spectral domain OCT. And come the second half of 2010s, we had the swept source come into existence, and the difference was the tunable light source. So then they changed the light source, and the detector was a balanced detector. It was not a spectrometer. And what happened as a clinical correlate was we had something which was even faster than the spectral domain OCT in terms of speed. Now, why it is called swept source? Because here the source of light is a tunable light source, and it sweeps around different frequencies. That's why it is called as a swept source. Now, the axial resolution of the spectral domain is definitely better because it uses a shorter wavelength, which we just saw. Whereas the swept source, the axial resolution is depending upon the sweep range of the tunable laser it uses. Lateral resolution is always mostly similar, as I already mentioned in the previous part of the talk. The depth is limited definitely in the spectral domain OCT because of limited range and the roll off of signal. Whereas swept source, because of using the longer wavelength, the depth assessment is much better. Phase stability more stable in the spectral domain, and the acquisition rate, although it's very high, it is still relatively slightly lower than the swept source OCT. So, as correlated to the speed, the motion artifacts in the spectral domain will be a shade more than the motion artifacts in the swept source OCT. So, these are the clinical aspects that we need to know. But again, you have to know what you're looking for, whether you're looking for depth or whether you're looking for axial resolution. That will decide which machine you will decide to ultimately fall back on. So we see the clinical correlate photographs of these machines, and here you see, here you have the swept source OCT pictures where you have a larger depth of penetration and a wider range, whereas in the spectral domain OCT you have a higher axial resolution but a less deep penetration with a lesser field of view. So these are the way the images look actually different when you see them in clinical practice, but by and large they'll give you a judgment of what you can expect if you buy a swept source and a spectral domain machine. So decision to choose depends on the axial resolution and whether you require the field or depth, or whether you are more concerned about the axial resolution. Now, what happens when you obtain a scan is something that we should know, because unless you understand what happens beyond the simple physics of the interferometer, you will not realize how you can tweak that information to your advantage. So the first step is image acquisition, which we just discussed using the interferometer setup, depending upon whichever machine you use, the spectral domain or the swept source. I'm not using the time domain here because it's no longer what do you call the in thing. After acquisition of the image, there is something called as image processing. In the processing, you get segmentation of the image, which is algorithm based. You get noise management, where you get technologies like pixel profiling or image averaging that are used. You have motion compensation to reduce the artifacts. Once the processed image is obtained, then you go in for software application and the final output, in which you have comparison to a reference database, which is stored in the machine, maybe variable with different machines, and proprietary software analysis and printouts. Now, what happens in conventional practice is we are besotted with the red, yellow, and the green without knowing what happens before. Because what happens before is more important than how it is shown to you. The amount of the kind of data that is shown to you is as good as the hardware and the method of acquisition rather than the colors that are thrown at you. So that is something that we should always remember. And for that, it's very important to understand what kind of image processing your individual OCT has, to understand what kind of quality it will ultimately throw at you at the end of the process. Now, if you see these scans, all four are RNFL scans. So with a acceptable recommended scan quality, this is how they look. Now, why they look so different is because of what I showed just in the previous slide, that is the processing mechanisms, the noise cancellation mechanisms, the image averaging mechanisms of all these machines are different. So you will definitely see a difference in the quality of the image. So the quality in terms of the quality score or the proprietary undisclosed methods of assessment of scan quality are already there in the machine, where you don't know how that value comes. But definitely when you have a visual impression of that particular scan, you definitely realize that there is something different going on in the machines. That's why the images look not exactly the same over the range of different machines. Needless to say, when the technology used is different, the references or the physics used is different slightly, you may not have the measurements which will be strictly comparable. Also, as far as the repeatability between devices are concerned, now this is slightly old data, but representative enough to tell you that different machines are different in terms of reproducibility, which is an important consideration in glaucoma, because here you are looking at assessment of progression. So if your repeatability indices are good, then the machine will suit you for your progression assessment and would be a good adjunct for your clinical practice in glaucoma. So here you see the interoperative reproducibility coefficients of different machines are different, and also the different machines have slightly different capabilities in terms of deciphering small values and getting measurements of the same place every time. So as a technique, although it is reproducible and reliable for most of its measurements, all machines don't have the same test retest variability, so that you have to do a basic homework before you go in and purchase a machine. So what differentiate men from the boys in glaucoma imaging? So once you have the image that has been got and processed, you want to ultimately understand how it will help you in assessment of progression. So there is something called as the image registration and the live tracking torsion adjustments that take place, which superimpose the previous image, the next image on the previous image, and give us a point-to-point comparison over time to help us identify progression even at those sub-micron levels, which help us in clinical decision making, especially for patients with progression in the green or preperimetric disease. So these technologies are proprietary. Some amount of high-end research and physics is involved, but definitely you see these tangible results when you see the printouts and when you see the outputs on a routine basis, you'll understand the difference for sure. So you have to be on the lookout for all these small things, whether they are available on your machine when you are going to use them for progression assessment in glaucoma. And the progression analysis should be at the optic nerve head, the nerve fiber layer, as well as the ganglion cell layer. So these are very important things and may not be available in all the machines, and that's why there will be a difference maybe in the pricing. Although they appear externally, they may appear the same, the model number may be different and the pricing may be hugely different. We'll see just by an example in the next slide. So these niche technologies translate into accurate and repeatable measurements of the same point on follow-up visits, and that is something that you should understand. So knowing your machine and limitations is important. This is a prototype example. You have a Cirrus 500 vis-a-vis a Cirrus 5000. So both are SD OCT platforms with scan speeds which are nearly the same. But what differentiates the two machines is the live tracking and the SLO. So whenever you have the live tracking and the SLO, it completely changes the game. Secondly, when you do a test-retest alignment in these two machines, you have a head and chin rest memory that is acting in the 500, whereas you have a vessel landmarks and a torsional adjustment that is taking place in the 5000. Needless to say, 5000 will be a better choice if I want to go ahead with glaucoma imaging rather than using a 500. Now, these are the certain small things which physics teaches us, which are behind the curtain, which we need to really identify before we use the machine. Otherwise, they would be ending up abusing the OCT rather than using it judiciously. So these differences make them apples and oranges in real world performance, and also the reason for the steep price difference by changing just 1 0 in the model. Now, if we compare the basic 4 technologies that are available, why I'm using these 4 platforms, because these are the usual 4 platforms that we see in clinical practice around us. No financial interest in this. So here you have the Cirrus 6000, the Spectralis OCT2 version, the Triton and the Solix. Here, except the other 3, the Triton is the only swept source OCT that is available. Now, if you see the data below, you will find a direct reference to my previous part of the talk. The scan speed definitely in the swept source OCT is high, although there are versions of the spectral domain which are even higher than the swept source here. Maybe some models of the swept source are on the which will be having astronomically high speeds. But again, I told you speed is not everything. Axial and lateral resolution, as I told you, for the swept source is slightly lesser than that for the spectral domain OCTs, which clinches the examination of glaucoma examination to the spectral domain in favor of the swept source in my mind. As far as the ONHL and NFL scan pattern are concerned, all these machines are slightly different. Most of them use the disc cube The Solix uses 5 alignment scans in addition to the disk cube, whereas the Spectralis is a completely different version. It uses 24 eggshell scans and 3 radial scans for measuring the nerve fiber layer and the disk. As far as the ANFAS live SLO-based tracking is concerned, it is available with the Cirrus and the Spectralis and the Solix. The Triton does not have an SLO. It has an image registration via an IR image. Tracking indicators, as seen on the printout or on the screen, are available for the on the printouts are available for the Cirrus and the Spectralis, whereas Triton and the Solix do not have tracking indicators in the progression printout to tell us whether the tracking has been done to our satisfaction or not. As far as the tracking technology is concerned, I told you that the SLO is ANFAS image of the SLO is used in three of the 4 technologies, whereas the IR fundus image is used in the Triton. The trademark tracking and noise reduction softwares and post processing are different for each machine, and they are trademarked and have different nomenclature. The ganglion cell analysis is one thing which is vastly different in all the different technologies. Needless to say, the values of what you get as a macular analysis or the ganglion cell analysis will be different. The Cirrus 6000 considers the ganglion cell IPL or the inner plexiform layer. The Spectralis segments the ganglion cell in isolation, whereas the Triton and the Solix are a mix of ganglion cell, nerve fiber layer, inner plexiform layer in varying proportions. As far as the manual segmentation override option is concerned, now this is very, very important. Why this option is important is because if you get segmentation artifacts due to a PVD or a vitreomacular traction or a traction on the disc, then you're not if you're not able to change the segmentation contour, then you're going to get a false positive or a false or artifact in the imaging, which may put you off track in your management of glaucoma assessment and progression. So manual overrides are not available currently in the Cirrus and the Triton, but they are available in the Spectralis and the Solix. The signal strength marker defined criteria are also different. Needless to say, these are basically proprietary. So you have to go by whichever manufacturer sells the machine to you to accept that as the imaging standard. But beyond that, you have to definitely look at the segmentation of the image. Reference databases are also slightly varied, but definitely they are never all encompassing for all patients. So always remember, progression using a same patient's data over time is the holy grail rather than comparing to any normative randomized database, because reference database, because it will never be all inclusive. Now coming to the calculation method for disk parameters in various machines. Again, these are very, very different. You have reference plane based calculations and non-reference plane based calculations. So understanding these are very, very important. Here you have to remember that these calculations of the so-called cup disk ratios are not the cup disk ratios that you see in clinical parlance, but these are going to be different because they are defined by the reference plane that is used to differentiate the cup and the disk. The prototypical examples that are used for making the cup disk ratio are the reference planes of above the RP. Now, the Zeiss has come up with a new technology, but most of these other machines, like the OptoView and Topcon, have reference planes around 120 and 150 microns above the RP. And in reference to that, the cup and the disk ratio are marked, and not the actual clinical cup disk ratio that you see on the on clinical examination. The non-reference plane-based calculations like the BMO, MRW are available in the Spectralis. Here you do not get any value of the cup disk ratio, but you directly get the mean rim width from the Brooks membrane to the ILM. As far as macular segmentation is concerned, also we saw that in the previous slide or the table that these are also very different depending on the machines, depending upon the segmentation capability and the trademark feature of each machine may be a part of the copyright. The GC-IPL for the Cirrus, the GCL plus and plus plus for the Topcon, the GCL of ganglion cell layer in the Spectralis, and the GCC, which consists of the GCL, IPL, and the NFL in the Avanti or the Solix. So again, you have to understand that these values are definitely not interchangeable because they are completely different things being measured here. So it depends. You have to follow one particular machine that you are interested in, and then you have to follow that particular value of data in your mind, because all these other values will be completely different. Now, as far as prototype printouts of machines are concerned, it is also very important for us to know, because the moment a machine is sold to us, we see there are 10 different representations that are possible. Now we have to understand the basic rationale, which prototype printouts really matter to us. Most of the time, what happens is that the examiner or the ophthalmologist is not the person taking the scans. We have trained technicians, and we are not most of the time on the console of the machine, because of which we cannot see all the permutations and combinations for our satisfaction there. So when the printouts come to us, it is important for us to understand which are the basic printouts that can actually cover all the aspects that we need for a due diligence for using scan in clinical practice. So I'll just give you a few examples. The representations, remember, are always only as good as the data that goes into making them. So the due diligence while acquiring data is very important. But once the presentations come to us, you have to remember that we are looking at the entire neuron. That is the macula, the RNFL, and the disc. So the representations that do not give us all the three parameters are always deemed to be incomplete and will not give you the complete picture, leading to a misdiagnosis in neurological cases and glaucoma likewise. So lack of details are non-negotiable. We need all the details when you want to put the data into perspective. So what do we exactly need to know from the printouts? One is the data has to be from the disc, RNFL, and the macula. The scan quality and the segmentation related information has to be present. Inter-eye asymmetry has to be depicted somewhere, and alignment details of successive maps in the progression map have to be represented somewhere, so that we are confident enough what the machine is doing is right, and we not have to run to the screen and onto the machine again and again to verify. So just giving you an example of the spectralis here in this case. Here, if you see, this is point 1. Here you have the data from the disc, the RNFL, and the ganglion cell. That is point number 1. Point number 2 and point number 3 are covered here, where you have the complete segmented image. You have the inter-eye asymmetry of both the eyes. And here you also have a macula segmentation. So you are having segmented images. You are sure that what the machine has done is correct, grossly at least. Then you have the alignment details of the progression maps in point number 4 here. Here you see what we call as a FODI axis. The FODI axis, the tolerance is within 0.1 to 0.2 degrees on either side of the baseline reference. So whenever you are actually seeing sequential images, you are actually seeing the FODI angle every time and seeing that it has not shifted more than the tolerance limit. If that is so, then obviously you will have a problems in measuring the same point repeatedly again and again. If you go to the same, apply the same logic to the cirrus, you have what is called as the R1 and R2. If you have the R2, it is the rotational as well as the translational alignment, whereas the R1 is only the translational alignment. So whenever you use whichever machine, you have to understand exactly where to look in the printout to see whether you've got all the boxes ticked, so that you can use this data perfectly in clinical practice. These are not the printouts that should be used in practice ideally. If you are supplementing these printouts with a printout of a segmented image, that is the ideal way to go. But most of the time we see patients moving around with these printouts. It is very, very difficult to understand how the images were taken, what was the quality, whether they were segmented properly or not when you get these images, because here you will have no clue as to what is happening behind the scenes. Now coming to the most important part, because it's like garbage in, garbage out. So due diligence in scan acquisition is the most important, because this will dictate how good the representation will be or the final data output you will get out of the machine, irrespective of what kind of machine you own. So it's very important for us to ensure proper registration of the baseline at the disc and the macula in all machines. Maintaining the quality indicators while acquiring the scans are very, very important. Verification of segmentation of the scans in OH, ONH, NFL, and accepting the contours after verification if the facility is available is very, very important step. This may not be available in all the machines that are sold. So it's very important because contour changes or segmentation changes can throw you off gear completely in progression assessment. So these are the way these are for representational purpose, because this is the machine I use the most. So the segmentation assessment of the optic nerve head of the RNFL, and if in case there is a segmentation affected by PVD or maybe any other changes, corrections can be done and the new contour line can be accepted. You have something like a contour changing and contour acceptance tool here, and you can definitely change the contour and accept it. If you find any aberrations, that will give you perfections in the in imaging and using it for progression. Now, important thing is this may look like very time consuming, but once the protocols are set, this is just a few seconds job, and you are through it, and you get an excellent image at the end of it. Printouts in the desired formats as per the availability is very important, and ensure they contain all the segmented images and all the boxes that we already said, the 4 points, so that you get the best output of whatever the machine you have. Now, in real life, the results in RNFL progression scans are here to see for all of you. So here, these scans are taken over a period of 16, 17, and 2018. So all over 3 years, you can see almost the images having absolute stability. What we mean to say here is that if you have the right technique, the right machine, and the right technology, and you use it in the appropriate way, structural progression is definitely going to help us in clinical decision making. So definitely, if you are trying to tackle this change from the 95th to 5th percentile within the 50 microns, you need definitely a lot of precision and due diligence to make the right decisions. Otherwise, you may be just trigger happy. So the take-home points are OCT usage in glaucoma has had a paradigm shift in the last 10 years owing to the rapid pace of developments in optoelectronics. It can be safely used in progression assessment with due diligence. It is important to understand the basics and physics behind the optical devices to make the right choices in practice. Knowledge of limitations and advantages of each technology help in its optimal use and avoids potential abuse. Strict adherence to laid down protocols combined with correct choice of devices help us to greatly in diagnosis and monitoring of structural progression in glaucoma. Achieving excellence is very, very important because, as we said, that the stakes are very high. The effect on patients' quality of life is drastic, and the disease can be blinding. So you choose the instrument that ticks all the boxes for glaucoma imaging, standardize the imaging conditions with attention to media changes over time, and acquisition protocols to achieve the best reproducibility with minimal test-retest variation. Trained, updated, sensitized, and dedicated staff for glaucoma imaging, if not done by own self. Printouts to include segmented images to assess scan quality and accuracy overall before using it in practice. Otherwise, redo it. If in doubt, especially in case changes are detected, you have to verify on the console and repeat in case of segmentation errors. Thank you for your patient hearing. We'll be very happy to answer questions later.
Thank you so much, sir.
Yeah.
Yes, sir. Thank you so much, sir. So